Hi, it's me, Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. And I am trying to make one video regarding not very common, but it is usually you can find in the pediatric age group, and the topic is the vein of Galen malformation. Regarding that, I want to present few things in front of you, and then we will. I try to present one case as a case of analogy, so then we can understand that how in our setup we try to dealt with this patient or how we can do. So, vein of Galen aneurysm malformation, uh, probably better termed as a median porencephalic arteriovenous malformation, are uncommon intracranial anomalies that tend to present dramatically during early childhood with feature of the left to right shunt and high output cardiac failure. So, as you know, the malformation account for less than 1 to 2% of all intracranial vascular malformation, but are the cause of the 30% of cerebral vascular malformation present in the pediatric age group, and it is also the most common antenatal or antenatally diagnosed intracranial vascular malformation, and there may be an increased male predilection than female, but it is there. And as you know, these malformations are only 1 to 2% of all intracranial vascular malformation, and it is cause of 30% of the cerebral vascular malformation and presenting especially in the pediatric age group. And as you know, the vein of Galen aneurysm. So here is a very good thing I want to mention. As I mentioned you, the vein of Galen aneurysm malformation, probably better termed as a median porencephalic arteriovenous malformation, and they are uncommon intracranial anomalies and that led to present dramatically during early childhood with features of the left to right shunt and right output cardiac failure. And as you know, the arterial or the artery connected by the vein, which is bypassing the capillaries, and that's why we are telling actually there is a two kind of or two types of the majorly you can understand the vein of Galen malformation. One is a mural and other is a choroidal. As a neurosurgeon, you know that you can see there is a cortical veins, and these cortical veins drain into the superior sagittal sinus, and this superior sagittal sinus drain into the into the connect with the transverse sinus, and where the transverse sinus it connect with the both transverse sinus, or we can say the superior sagittal sinus. So superior sagittal sinus when it is when you see it is more getting it is on the posterior part, it is the straight sinus attached with it, and then this straight sinus and the superior sagittal sinus at the confluence, it is making two more sinuses on both sides, and by the name of it is called the transverse sinus. And these transverse sinus, on the one in the right side, one in the left side, and when these transverse sinus came out from the jugular foramen out of the skull, and came and become the part of the neck, and extra axillary part of this straight sinus becomes the name jugular vein. And you know the jugular vein is going down to the major veins in the subclavian, and then combination of axillary subclavian, and then it going towards the veins right right atrium. through the superior vena cava. So this is the anatomical understanding by this picture I wanted to show you. And this is a post-operative picture of the, you can understand here that there is a return to the normal brain circulation, and this is the post-treatment situation. Actually, these photographs I took deliberately, and because from the internet, because and I want to present so you can understand, and I am hoping you are understanding very, very well. In this picture, you can appreciate there is a inferior cerebral veins, you can see, then superior cerebellar vein, then precentral cerebellar vein, and superior Vernian vein. These all are going into the straight sinus, and then into the great cerebral vein, or we can say the vein of Galen. And this vein of Galen, when it become a fusiform and become enlarged, and as you saw the picture which I show you just before, and you appreciated very well that how it looked like. Here you can see there, this is the normal way the artery converting or with multiple division happens, and the blood goes in the multiple number of capillaries, and these capillaries become converge and become the venules and the vein. But here you can see what happened. You can see here the directly artery go and skipping the capillary meshwork and directly entering, and it is causing the what I mentioned here, high output of the artery, and it caused the high output cardiac failure, especially in the pediatric age group. If you see this picture is showing how the you can see the vein of Galen. There is and everything in front of you. There is even the cavernous sinus has been mentioned very well. Superior temporal vein is, and you can appreciate here. Anterior facial vein you can appreciate here. Pterygoid plexus you can appreciate here. Superior sagittal sinus you can see. Then superior sagittal sinus, and there we have the inferior sagittal sinus you can see there, and you can see the vein of the Galen here. There, and this after inferior sagittal sinus and a convergence into the vein of the Galen, and it is going to the straight sinus with the inferior sagittal sinus, and this combination, inferior sagittal sinus and the vein of Galen, can make the straight sinus. And as I mentioned you, the straight sinus will combine with the superior sagittal sinus and then divide further into the right transverse sinus and the left transverse sinus, which further as traverse and came out of the skull. Then it becomes the jugular vein, right jugular vein and the left jugular vein. It is here. So increasingly the diagnosis, the clinical presentation, the diagnosis is being made antenatally with the third trimester antenatal ultrasound. Presentation is often with the high output cardiac failure in the neonatal period. Although low flow aneurysm may remain, we can say, the undetected into the adulthood, as much as 80% of the cardiac output may shunt through the fistula, and the presentation does, however, vary with the type of malformation and different type present at different ages. The neonates usually the choroid type and the high output cardiac failure and the cranial bruit. In neonate you can find, because the presentation does, however, vary with the type of malformation and different type of present at different age group. So I want to tell you according to the first of all age group, and then if possible then I will tell you in detail further. So you can appreciate that the findings in neonate usually they are usually choroidal type. I just show you before the choroidal type and the mural type, and and in neonate you will find the more choroidal type, and they have a high output cardiac failure, and you can find the cranial bruit in it. In the infant age, you will find more the mural type. It is not choroidal type, means less choroidal, means not very much. Usually you can find the mural type, and developmental delay is there, and hydrocephalus, sorry, and then hydrocephalus may occur due to the venous hypertension or aqueduct of stenosis. What happened here? I repeat, there the usually in infant usually mural type, and hydrocephalus may occur due to the venous hypertension or aqueduct of stenosis. In children, usually you find the mural type and developmental delay and hydrocephalus. So in the children, you will find the developmental delay. In infant, there is not much time, you can check the developmental delay. There you can find the hydrocephalus. In infant and child, only one difference is that there in children you will find the developmental delay. Otherwise, in infant and child you will find the mural type, and in both situations you can find the hydrocephalus. But in infant you can find the hydrocephalus maybe because of the venous hypertension or aqueductal stenosis. But in a infant, in a neonate, you can find the choroidal type, and the high output failure and the cranial bruit. One thing I want to mention here, you can appreciate this is a CT scan, and CT scan showing how much dilatation and you can appreciate there is a significantly in sagittal section. You can see there's a huge I want to mention the dilatation of the vein of Galen here, and you can appreciate here. Real view, you can appreciate the dilatation of the vein of Galen and malformation of the vein of Galen. You can appreciate this with this CT scan and a 3D and a reconstruction. You can see how this big the dilatation of the vein of Galen, and you can appreciate very well, and you can understand very well. Yes, regarding the pathology, the anomaly is actually due to cerebral arteriovenous fistula of the median porencephalic vein, and this is occurring at a 6 to 11 week of gestation, and not a malformation, no nidus present, and the original connection between the choroidal arteries that initially were supplying the developing brain tissue before the shift to the developing cerebral vessels, and median porencephalic vein persist and result in enlargement of the latter, and hence if you see that the arterial blood is shunted from which is high pressure and this choroidal artery to the low pressure vein of the Galen, and that's why these significant dilatation happen because of the significant pressure of the artery going directly into the very low pressure veins, and actually that this this fails to regress and become aneurysmal, and this it drain via the straight sinus and present only in a 50% of, or we can say the persistent falcine sinus, and the vein of Galen does not form at there, and the hemodynamically cerebellar arterial venous fistula involving vein of Galen can be subdivided into two groups, and the true vein of Galen malformation, and other one is a vein of Galen dilatation secondary to the high flow parenchymal AVM draining into the vessels. So that's why we have to understand which kind of the vein of Galen is that, vein of Galen malformation is that. One is a true vein of Galen malformation, and other one is a vein of Galen dilatation secondary to the high flow parenchyma AVM draining into the vessels. And I want to talk about here the little bit about the classification here. There is one classification, we can say the malformation have been classified in a number of ways, starting as early as in 1960 when Litwick et al. Recognized the need for the classification system in the region of the vein of Galen, and over the year the most commonly used system of classification are according to the clinical presentation, as I mentioned before. The how clinical immunate, the clinical presentation is the cranial bruit you can hear, and you can see the what I can say, the high output cardiac failure, and it is usually choroidal type, and in infant it is it is causing the venous hypertension, and maybe because of the aqueduct of stenosis, and the hydrocephalus will happen, and it is a mural type, and in children also the same way, and that's and one way of the classification I already mentioned before. The one is a true vein of Galen malformation, and other one is the only dilatation of the vein of Galen secondary to the high flow parenchymal AVM draining into the vessel. So other one is a Yazir-Gill classification, which is type 1, type 2, type 3 and type 4, and one more classification which is called the Lazunge's classification, and which is the choroidal and the mural type, and Moradzevi et al. In 1913 proposed a new classification system, but not validated up till now, incorporating two important factors, heart failure and age, but it is not very common or very popular nowadays. I want to show you some radiological features of this. You can appreciate here, this is the transcranial ultrasound, and you can appreciate the picture because we are doing for the diagnosis, we are doing the radiologically, we can use the transcranial Doppler or transcranial ultrasound, and you can appreciate this. This is also a view of a transcranial ultrasound or Doppler. This is also software enhanced transcranial Doppler, showing you can see the flow, arterial flow, venous flow, and you can appreciate the structure also. Here again you can appreciate the situation and you can understand. This is the digital subtraction 4-vessel cerebral angiogram, and you can appreciate this also, how it is behave and how you can see. You can see here there is a dilatation of the vein of Galen, hugely dilated vein. This is the MR, and MR showing that kind of presentation. These figures I just wanted to show you because you can understand, and then I want to talk about it little. So as you know, the antenatal ultrasound we can do also. I just wanted to present to you ultrasound and then Doppler, and then now I want to talk about, already I showed all kind of pictures of the different radiological modalities, and here with increased availability and the quality of the antenatal ultrasound, diagnosis is increasingly made prior to delivery, and antenatal detection is however mostly reported late in pregnancy in third trimester, and the dilated median porencephalic vein appear as we can say anechoic structure in the midline posteriorly and demonstrate prominent flow on Doppler examination, and shunting may lead to complications such as hydrops fetalis or the fetal cardiomegaly. this hydrofetalis or fetal cardiomegaly and shunting, and because you can appreciate this by the antenatal ultrasound or a porencephalic vein, which I am telling, and a porencephalic vein malformation, which is also the name of the, or we can say this is the vein of Galen dilatation or malformation, and diagnosis now you can made by the prior to the delivery. One more thing I want to present here, that the CT and MRI, both CT and MRI can be used to delineate the malformation across sectionally. So the CT angiography, CTA, in neonate with high output cardiac failure is technically challenging due to the small volume of contrast and very rapid passage of the contrast through the circulation. So it is very tough and very challenging, and very smart technician can manage it appropriately. Otherwise, it is little difficult and troublesome for everybody. CT angiogram showing a lot of great detail about it, and then MRI angiography, the dilated feeding and the draining vessels appear as a flow void on T2 weighted image, and MRA may also be performed, which would better delineate the vascular anatomy here. Conventional, or we can say the digital subtraction 4 vessel cerebral angiogram is also very important, and I'll show you one picture of this also. So ideally you know that the angiography of the digital subtraction 4 vessel cerebral angiogram is still the gold standard in all characterization of this lesion, and it enables to individual catheterized feeding vessels, and morphologically a spherical or ellipsoid varix may be visualized, and the venous drainage is via median porencephalic vein malformation and the straight sinus if present, and then out via the transverse sigmoid sinus by definition, and there should be no drainage to the other component of the deep venous system. So, as you know, this is the importance of the 4 vessel cerebral angiogram. And treatment and prognosis, if you want to talk about the treatment and prognosis, so prior to the endovascular intervention, the prognosis was dismal with 100% mortality without treatment and 90% mortality following surgical attempt. And ideally, embolization is deferred until 6 months of the age for the choroidal vein of Galen arterial malformation, and later for the mural type to allow the cavernous sinus to mature, and if cardiac failure is refractory to the medical management, then embolism may be performed sooner. So both venous and the arterial embolization is possible, and depending upon the number of the feeders, and controversy persist in regarding to the optimal approach, and that's why the optional include like the arterial feeder and the fistula occlusion, or I can say the trocholar or transvenous embolization of the dilated vein, complete or incomplete occlusion. It depends definitely how expert the operator is when the things are coming in the hand on the embolization. Both coils and acrylic glue can be used in the single procedure or in a stage procedure. So the radiosurgery has been tried, but is limited to patients who are not candidate for the other treatment modalities. Hydrocephalus is typically not shunted as this may exacerbate cerebral ischemia, and by altering the cerebral hemodynamic and due to the increased risk of the intraventricular hemorrhage, the prognosis is determined mainly by the presence or the absence of the cardiac failure. So thus the choroidal type and those presenting in the neonate period do poorly. As I was mentioning you here that both coil and acrylic glue can be used in a single procedure for we can say or in the state procedure, but radiosurgery have been tried and it is limited to the patient who are not candidate for other treatment modalities, and the hydrocephalus typically not shunted as they may exacerbate the cerebral ischemia by altering the cerebral hemodynamics and due to the increased risk of the intraventricular hemorrhage, and the prognosis is determined mainly by the presence or absence of the cardiac failure, and thus the choroidal type and these presenting in the neonatal period so do poorly. And I want to show you here one picture of the. This is a picture I chose to put in my video, and you can see there is a vein of Galen dilatation in the digital subtraction cerebral angiogram, and then he and the operator did the coiling, interventional radiologist, and you can appreciate how the coiling work and almost gone. You can see this and the dilatation almost is reduced. I must mention this that so I think very appreciable picture for us that these kind of work, which is definitely very challenging, has been done greatly. So vein of Galen malformation are named after the Galen of Pregomona, and also known as the Alias Galenus, or we can say the Clydius Galenus, AD in AD 129 to 199, a Greek physician and the philosopher in the Roman Empire. And this Clydius Galenus, or we can say Alias Galenus, and he actually the name actually put behind him for him. And differential diagnosis, once abnormal vessels are identified, there is usually a little diagnostic uncertainty, with the only two entities to be considered being, one is the arteriovenous malformation or vascular intracranial malformation. So these are two very important things. And now I want to present one case as an analogy. Actually, a patient in a 5-day-old full-term female who present with the heart failure and seizures, and on examination full fontanelle and the head circumference is 35 centimeter and the systolic cardiac bruit and mild right-sided hemiparesis. The differential diagnosis of the vein of Galen malformation include true arteriovenous malformation involving the thalamus and nearby structure and intracranial hemorrhage secondary to the germinal matrix hemorrhage and or dural venous sinus thrombosis. So the differential diagnosis of the vein of Galen malformation include true, as I mentioned before, a true arteriovenous malformation involving the thalamus and nearby structure and intracranial hemorrhage secondary to the germinal matrix hemorrhage and or during venous sinus thrombosis. I want to show one picture from the book, and which is very much explanatory. I took this picture from the book, and it is mentioning, and you can appreciating here, there is how the vein of Galen you can appreciate, even though the one more vein you can realize here. And then in this both digital subtraction cerebral angiogram, then you can appreciate the different arteries are entering directly into the vein of Galen, and you can understand and appreciate very well. So, as you know, the imaging reveal an arteriovenous malformation centered around the deep cerebral venous structure, and there is a persistent false sinus and an enlarged straight sinus. The midline venous pouch is consistent with the vein of Galen malformation. However, not all medicine engorged venous structure are vein of Galen malformation, and the differential diagnosis includes a true brain arteriovenous malformation of the thalamus and or surrounding structure. And the further workup, the laboratory, routine lab, ECG, echocardiogram, we can say the continuous EEG. So these all are very important to do. MRI, MRA, MRV to aid in the assessment of the vascular anatomy. Non-contrast and LAT CT is often useful to assess for the hydrocephalus, formal catheter or angiography. And you know, the term vein of Galen malformation is a misnomer, and the malformation actually involve a persistent fetal vessel known as the median porencephalic vein of we can say Markowitz, and this vein is present during the 3rd to 11th week of gestation and drain many deep-seated structure as the brain develop, and the anterior portion of the vein regress, and the internal cerebral vein or surrounding territory. So in healthy term, infant, the internal cerebral vein drain into the posterior portion of the previously termed median porencephalic vein, and now called the vein of the Galen. And in vein of the Galen malformation, the anterior portion of the vein does not regress as it normally should. So as you know, the arterial supply to these malformation is oftentimes is combination of persistent fetal vessels that also fail to regress. So branches of the anterior cerebral arteries and the anterior choroidal arteries and the posterior communicating arteries and the posterior choroidal arteries may terminate directly into the persistent vein and creating a large arteriovenous pouch. A vein of Galen malformation therefore present a true arteriovenous fistula, and it is important to realize that arteriovenous malformation of the thalamus and the surrounding structure may drain into a dilated normal vein of Galen, and these may be mistaken by vein of Galen malformation, and catheter angiography is usually able to delineate between the two. It is important to realize that the arteriovenous malformation of the thalamus and the surrounding structure may drain into the dilated normal vein of Galen, and these may be mistaken for the vein of Galen malformation. That's why I'm repeating this, and the catheter angiography is usually able to delineate between the two, and the vein of Galen malformation poses several problems to the newborn, and high output cardiac failure is most worrisome, and in acute setting the fistula acts as a venous sump, pulling a significant portion of the infant circulating blood volume through. The second worrisome feature is a phenomena known as the melting brain syndrome, and it is a very a disastrous condition when the melting brain syndrome has been started, and the high venous pressure associated with the lesion interface and the white matter development can cause the secondary leukomalacia and the severe mental retardation, seizures, and the hydrocephalus. And this mental retardation you will find in the childhood age not in the other age group. The other, definitely it is difficult to understand. It's a very the child is very small at that time, but as you know, the seizure and the hydrocephalus may also develop in many infant and children. And according to the Yadir-Gill classification, there are four classes of the vein of the Galen malformation, and I want to mention here in front of you that there is according to the Yadir-Gill classification, the fourth and type of the arteriovenous malformation present in the vein of Galen malformation can predict the clinical presentation. Primary type is a choroidal or direct, which is there exists a small cisternal fistula at high flow shunting within the wall of the venous aneurysm between the vein of Galen and anterior pericallosal artery and the posterior pericallosal artery or the posterior cerebral artery. So the primary type, the choroidal or the direct one, that exists in a small cisternal fistula, high flow shunting within the wall of the venous aneurysm between the vein of Galen and the anterior pericallosal artery, posterior pericallosal artery, and posterior cerebral artery. Second type, or the primary type 2, it is a mural network like the arterial network of the multiple fistulas exists between the vein of Galen and the thalamo-perforating vessel, and in interposing arterial work is usually situated in the quadrigeminal plate system and is associated with lower brain flow than found in type 1 malformation. Type 3 is present as a combination of type 1 and type 2 vein of Galen malformation, in which are high flow in nature, but type 4 present a diffuse parenchymal arteriovenous malformation with primary drainage into the vein of Galen, or we can say the vein of Galen aneurysmal dilatation. Clinical presentation, as you know, I mentioned here, the neonate will usually present significantly cardiorespiratory failure or at following birth. Frequently, these children will demonstrate cardiac compromise in utero, or we can say hydrops, and these symptoms usually associated with a type 1 high flow vein of Galen malformation, with the vast majority of a neonate exhibiting the sign of high output cardiac failure, and many will additionally experiencing a severe pulmonary hypertension. In infant, I already mentioned, as a result of the cerebral steal phenomena or type 2 vein of the Galen malformation. So in infant, as a result of the cerebral steal phenomena in type 2 vein of Galen malformation, most infant will have progressive macrocephaly or hydrocephalus. Many may additionally experiencing new onset of seizure, and the development of hydrocephalus may be non-communicating secondary to the aneurysmal compression of the aqueduct of Sylvius, or communicating result from the intracranial venous hypertension, the presence of subarachnoid blood, or both. Children and older children usually have symptom of headache associated with the subarachnoid bleed, and otherwise these lesions are usually asymptomatic and found by MRI. So these malformations are usually small and limited shunting, and frequently type 4 malformation will be included in this age group also, means children or the older age group. Treatment option, as you know, most of these lesions are treated endovascularly, both transarterial, transvenous, and may be used oftentimes combination of both the necessary to decrease flow through the fistula. And the goal of treatment is not always complete obliteration of fistula. The goal is not always the complete obliteration of fistula, but rather the amelioration of the symptoms secondary to the high output cardiac failure, and the transarterial embolization. Transarterial embolization is performed through the umbilical artery in neonate or the femoral artery in the older infant, and the liquid embolic such as the N-butyl cyanoacrylate NBCA, which is called, and the femoral through the femoral artery in the older infant, and this liquid embolic, as I mentioned, and the other liquid embolic we have, which is called the ethylene vinyl alcohol and a copolymer, which is called the onyx. This ethylene vinyl alcohol copolymer are commonly used to embolize the feeding, and ethylene vinyl alcohol copolymer and embolize the feeding arterial pedicle where we can reach. Additionally, coil embolization may be used as an adjunct in some cases. Transvenous embolization may also be used, and the coil embolization of the venous pouch, I want to say here the dilated porencephalic vein, so the help reduce flow through the malformation. But this approach is usually reserved for when transarterial option have been exhausted. So when the transarterial option has been exhausted, then I think we can choose the then we can choose the transvenous approach. But as you know, there is intravenous embolization may also be used, and coil embolization of venous pouch, it can be used and help reduce flow through the malformation. But this approach is usually reserved for when transarterial approach have been exhausted. Surgical techniques such as the clip ligation of the arterial feeder and transection of the malformation itself have largely been abandoned, secondary to the high morbidity and very high mortality, because the surgery play I mentioned a role in the treatment of hydrocephalus, but the ventriculoperitoneal shunt or endoscopic third ventriculostomy related to the aqueductal stenosis caused by compensation from the malformation. So as you know, this treatment option, complex lesion, should be staged to allow more controlled devascularization. This can help and prevent the complications such as the perfusion and background or the venous. And they know the people they are treating such kind of patient, then they knows that how. So I tried to explain this vein of Galen malformation and my according to my knowledge and my experience, and definitely you liked it. If you like it, please subscribe it, share it, and support us. Thank you so much. See you with one more video.